Je suis très heureux aujourd'hui de vous accueillir à cette conférence intitulée La co-création, mise en œuvre et évaluation d'une plateforme de santé numérique pour soutenir les transitions de soins en réadaptation. C'est avec un grand plaisir que nous recevons aujourd'hui Professeure Sara Ahmed, qui est chercheuse en biologie et directrice scientifique du Réseau de la santé numérique du Québec. Ces travaux portent sur le développement des solutions numériques centrées sur les patients, ainsi afin d'améliorer la qualité et l'équité des soins, notamment en réadaptation. Sans plus tarder, je cède la parole à professeur Sara Ahmed. Je vais commencer.
Merci beaucoup, Mohamed, et merci pour l'invitation pour venir et présenter nos travaux en santé numérique et réadaptation. Je vais présenter en anglais, mais si jamais il y a des questions, s'il vous plaît, être à l'aise de demander dans les deux langues. So I'm happy to share with you the work that we've been doing in Brilliant. I'll just start off by sharing a little bit about what Brilliant is. It's an initiative that was started right before COVID to work with our partners to put in place a learning health community around digital health and the use of data in rehabilitation within our living labs, so our clinical sites and with our community partners. While the technology spans everything from virtual reality led by colleagues in the Brilliant Initiative like Anouk Lamontagne and Philippe Archambault and others, I will focus today on the digital health component of the work we're doing in Brilliant. Voilà. Just to say there's a huge team behind this work of students and research assistants and co-principal investigators on the health informatics piece include Dr. Auger and Dr. Thomas, supporting the rollout of the digital platform in different regions within our CRIR partner sites, CIUSSS Centre Sud, Laval, and myself in CIUSSS West. The core team is working actively to support this work across all of the sites, and just want to say thank you because without them we can't do this work effectively and so broadly. I'm just going to start by talking a little bit about the large need that we have right now for rehabilitation and many of the challenges within our health system will require really turning and taking the pillars of rehabilitation care in order to address them. It has to do with the demographics globally, but also across Canada. We know that 1 in 3 people around the world will require rehabilitation at some point in their life. Closer to home, 8 million live with at least one disability, sometimes more. And while the evidence shows that early and intensive rehabilitation is really key for optimizing outcomes, including function and participation, we know that that's not happening. So, for example, in stroke, only 19% of patients across Canada receive stroke within the first 30 days. And it's unfortunate because we know that if we could do this well and scale up early and intensive rehabilitation, that we can have people home sooner. The evidence shows at least within 90 days if they start rehabilitation right away. And there's lower likelihood of poor outcomes and being admitted into long-term care. The challenge is scaling up accessible early and intense rehabilitation. Overall, in our health system, 46% report at least one unhealth need, and almost 50%, half of those who require rehabilitation, are challenged in receiving it. And if we look at specific populations, sometimes that number is even higher. For example, in stroke, 62% have delayed access to rehabilitation. And one of the reasons why scaling up this access is complex is because our health system is complex and we have to manage transitions of care. So how do we get people effectively from the hospital if they need inpatient rehabilitation to be able to access that early and then back into the community? And how do we even decide who goes where in an effective and a way that is consistent and can be scaled up? We know that if we could do this well, for example, care transition teams can help reduce readmissions back into hospital from 18 to 90%, Programs like early supported discharge can help increase intensity of rehabilitation in environments that patients and families are more comfortable, so at home. But the challenge is trying to make this a staple of our health system and making it accessible to a large number of people. And digital health will play an important role in this because there are many parts that were required in order to make transitions of care successful. We need standardized assessment, we need data-driven discharge planning, effective communication and sharing of information, but also effective self-management support for patients and families so that when they're going through these transitions, they don't feel lost and have the information and the skills they need to manage their health. And all of that, of course, we want to do in an equitable manner, which means that we want to be able to personalize the care needed and the information needed so that everyone has an equal opportunity to optimize their health. So where do digital tools play a role in help in assisting with this? From the acute setting, for example, we know that if we could do real-time monitoring and data-driven discharge planning, we improve outcomes and not having people return back into the hospital. In rehabilitation, technologies play an important role in capturing outcomes, but also tracking progress, helping to develop therapy protocols that are personalized, but also tailor those over time as they show improvements. And then, of course, be able to collect data, learn from it, and have outcome reporting not only at individual patient levels, but at larger program levels and organizational level of data. The other big part, and this is what comes up over and over in the work that we're doing and speaking to different communities and patient groups, is the discharge back into the community. And often people feel they get excellent care when they're in the health system, but they return home and they feel they have less resources and don't know where to turn. So digital health can play an important role in helping access those community resources. And that requires putting in place digital solutions on the patient and family side once they go home, but also having that coordinated access to information through clinician portals and hopefully eventually the electronic health record once it's available across the province. I'm going to share with you a little bit before I talk about the platform, how we came to co-design the platform with our patient partners. So typically we go through three steps of co-creation, which is really understanding what the needs are and what the pain points are. We've combined those into up to now 24 larger groups, and then we translate those into technology solutions using framework like the World Health Organization, which has defined for us where digital health can play a role in addressing different pain points within the health system. So that work we've done early on, and it's resulted into a suite of potential areas that we can address in order to improve transitions of care, both when individuals are within the health system and when they return home. I'm going to delve into these a little bit more because we took essentially these areas and we discussed them and reviewed them in more detail with patients and caregivers as well as clinicians across our different health regions. We conducted semi-structured interviews, and this is supported by the work of Dora, who did our postdoctoral fellowship with us in Brilliant. And essentially, when we looked at the needs that patients had, they fell into three broad categories. One is the need for them to understand and feel in control of what comes next. So understanding really what are they experiencing now, what will they experience later, and understanding how technology can help. The need to act and see results. So being able to have information that can help them decide, are they progressing? Is there something else that they need? And then finally, the need to feel connected and supported and know where to reach out if they have additional needs, especially later on past the first 6 months and 1 year after receiving rehabilitation. So, for example, the need to be understood and feel in control. Some of the quotes that came from patient partners is the fact that the team explained to me step by step what's going to happen. I find that really reassuring. So we have to make sure that when we translate this into a digital solution, that continues to carry over. The additional parts that maybe don't exist right now where technology can help is being able to graph and track progress and be able to review that progress with their clinical team. So the information must be timely, trusted, and tailored. And so the feedback that we got about this area is helping us design the functionalities with our industry partner to be able to better support patients as they go through that transition. The second, I need to act and see the results. Well, there's a lot of patient education and information that's shared. What we found is that it's sometimes quite different across sites. And so one of the areas that patients mentioned is, well, to be able to see it or have it demonstrated really helps me understand what I need to do. Having a digital journal, for example, to follow up and be able to show what's been done is another thing that they mentioned. The third pillar, I need to connect and feel supported. This came down a lot around communication. If it was done via platform, I would definitely want to be able to access someone to answer my questions. So that raises the question is how long are people tied into the health system and who would that person be? But it identified it as a need. And as a result, we're able to think about how we would make this a functionality, what could be automated in order, now with generative AI and chatbots to be able to provide that support versus when would a human interaction be needed either from a community partner or a health system partner. So the right support that extends beyond the patient and requires some form of input is another area that we're looking at. And the implication for the platform is that it has to be robust, user-friendly, and be able to essentially push questions as well as receive information through the portal. So what we heard from patients and caregivers is that they want to be understood and feel in control, be able to connect and feel supported, but also have information to be able to act and track and see how their progression is going. We then took that feedback from patients and caregivers, and they also prioritized and ranked those different functionalities. And we showed them to clinicians. We shared the feedback with clinicians of what patients said. We showed them the list of potential functionalities that we adjusted and adapted based on the feedback from caregivers and patients. And then we went through a deliberative, reflective process with clinicians to say, what would be a priority to include within the platform and within the current study that we're evaluating. We'd like to have everything, but we know that when we overwhelm users with too much information and complexity within a platform, it reduces adoption. But also resources are limited. So where should we start and what's likely to be what's most important and what's likely to have the most impact? So we did this across with groups, patient groups and clinician groups across the CIUSSS Centre-Ouest, Sud, and CIUSSS Laval. What you see here is essentially the functionalities that are grouped according to treatment plan and progress, resources, social and community, and calendar. And you see what's in green is what was weighted the most and ranked the highest importance by patients and caregivers. So things that tended to be around resources, social community, organization of being able to know when they're being scheduled to see which clinician, these were the types of things that emerged as very important for patients and caregivers. We then took that and showed it to clinicians and asked them to essentially take each functionality and decide yes, no, or need more information to decide whether to keep the functionality. And after that triage process, we had 12 retained functionalities, which essentially are the ones that you see with an X that are on the right-hand side. So that helped to prioritize, and it touched a little bit on treatment and plan and progress, resources, social and community. The pattern that we saw that emerged is essentially where technology can help support or replace some of what already happens within rehabilitation was very highly supported. Things that required more data entry or information were less supported. So there is a relationship a little bit with the concern that does it add more work to use the platform versus what can be integrated into the usual way of doing things. This is where we find that these sessions are really a time of learning and reflection around, is having that added step of adding more information going to provide data that will help improve outcomes later on? And is it really worth it, and awaiting that in importance of including a specific functionality? So once we had the priorities, we went to the platform design. And essentially, if you zoom out, the design of the platform is around five main modules. One is around standardized assessments. So having both patient-reported outcomes, but clinician assessments that are typically done in rehabilitation, like the Berg Balance Scale. Quality improvement dashboards that essentially looks at all the information that's implemented and picking out indicators that are most meaningful to look at the quality of the services offered. In terms of clinician tools, communication tools between team members and with patient family, huge importance, regardless of which trajectory of care, and I will talk to you about which patient populations we're talking about, was the shared intervention plan. That came out consistently as being a very important part of the platform, is being able to use the data that's inputted to help set goals with patients and families, and then track the progress of those goals within the platform. And then, of course, linking that to what the patient needs to do, and reporting back progress and recommendations of what they can do next, especially when they're back home and in the community. This is a CHR funded project, and initially when we applied for the grant, we identified acquired brain injury as the main patient population. So the goal is to evaluate whether implementing the platform does improve outcomes and rehabilitation. The outcome that we picked is rehabilitation intensity, with the hypothesis that being able to share information in all the modules that you saw would help reduce some of the administrative steps, but also help support the joint shared decision-making between team members and families, and be able to result in more intense rehabilitation. And we can talk about that. We've sort of shifted that primary outcome to maybe focus more around patient function and quality of life because of the nature of the platform right now. And you'll see what I mean when I share a little bit more detail of the populations. The other area that we're looking at as secondary outcomes is improvement in coordination, and then mid and more long-term outcomes like quality of life, caregiver experience, and system efficiency. Does it help save time in terms of referral and discharge, and in terms of administrative work for clinicians? When we started working with the sites, and this is where integrated knowledge translation plays an important role, is the sites shifted to other clinical programs that they wanted to focus on for using the platform. It had to do with level of readiness of programs, where the interest lied at the time, and where they felt it would be the most feasible to integrate the platform. So this is where we adapted quickly, and thankfully our industry partner adapted with us, and we were able to adapt the platform to these different trajectories. So we have both the targets within our trial are both patients, are patients and caregivers, but also clinicians and managers that we will be evaluating outcomes for. So the first phase of the trial is first to say, okay, we have this triage, we've come to this set of functionalities to work with the industry partner Gray Box in order to integrate the functionalities within their platform, and then go through a reflective process with clinicians to say, does it meet the requirements? What are the likely barriers and facilitators? And to troubleshoot before we implement and evaluate the platform. So the trajectories that I referred to in each CIUSSS and CIUSSS is slightly different. So both CIUSSS Centre-Ouest and Sud are focusing on acquired brain injury populations across their trajectory. And CIUSSS Laval, it's the SAD program, so soutien à domicile. So it's home care for hip and knee, post hip and knee replacement, And in CIUSSS Outaouais, they asked to use the platform within when they provide a prosthesis for populations, the amputee population. The way that we work across each of the sites is to map out the trajectory without technology and ask the question, where are there pain points? And is it a technology question or something else that needs to be changed, like, for example, an assessment? And from there, we're able to map out the trajectory, what we call the modified or enhanced trajectory with technology support. And so for each trajectory, we have several pain points that have been mapped out and how the platform helps address that pain point. And this just helps to ensure that we don't end up with a technology that seems nice and fancy, but that actually has a solution to the problem that was identified. So for example, and these are just examples, they're about a list of over 20 in each trajectory. But siloed interdisciplinary communication, so fragmented documentation and how that could be shared. Another is resource. So how do we combine all of our educational resources so that all clinicians can choose from it and have consistent messaging to patients and family? Better understanding what's happening during transitions. So there's high risk of duplication of data or data information being lost and not being addressed for the patient if there is something they need. Or having replication and evaluations done again at each point in the trajectory of care. The other is disconnected post, follow-up. So follow-up is a huge area where digital health can help. If it could be as passive as just monitoring outcomes and having alerts of something, is identified as problematic, or actively integrated into the health system where the team can do something if the patient is experiencing difficulty. And so in the example for amputees, they're able to ensure better adherence and use of the prosthesis that's prescribed. So this must seem huge to you when you look at this and you see all these trajectories, and the question arises, well, how in the world can you develop a platform for all of these conditions at once? And we had that reflection very early on. So as much as we want to do integrated KT, we were also thinking, okay, how will this be manageable? And this is where working with an industry partner who's adapted their platform to several patient population really helps, because we're able to work with their experience. But also what became very clear is that there's a core set of needs that, regardless of which rehabilitation, will repeat itself. And it's a matter of adapting it to each of the trajectories. So thinking about what is core and can be used across all trajectory, and then what really needs to be tweaked for each trajectory in terms of what their needs are. And of course, there's a prioritization that goes, prioritization is a constant process within digital health co-creation, because even in the implementation pilot testing phase, if a clinical team comes out with a need, and we have to weigh what is the cost and the resources versus what is the potential benefit and impact. And, how many patients is it going to really benefit, and then make a decision about whether it will be implemented or do we wait and do this in another phase. So some of the things that are quite core are things like the plan d'intervention, forms, even if some of the questions have to be replaced, but the core forms are the same. Being able to follow the patient file over time, and alerts. So these are core functionalities, you can say, within the digital health platform that can be readily adapted in order to be able to adjust to different trajectories. And really, the success of digital health will depend to what extent will our platforms that we use within the health system be adaptable and require less and less technical sort of back end heavy changes, versus front end the team can adapt it to what their needs are, even if the core is the same. So this is part of what we're learning is also around this organizational rollout of digital health tools in a way that can address multiple program needs as well as a specific trajectory. So with the functionalities and what we hope to achieve within this trial is that layer of functionalities that will help track outcomes for patients and standardize assessment to make decisions around referral and discharge that are more harmonized and enhance clinician decision making. Be able to offload some of the administrative and searching for data parts of clinical care and be able to share it more effectively through dashboards. So having that process efficiency, reducing overall times within the system of needing to make decisions, and you could think beyond rehabilitation trajectories and just being able eventually in the future to feed in other information like availability of beds, for example, and where can we send patients once the system, the Réseau de santé, becomes a little bit more connected. But of course, especially is the patient-centered care. And this is where we're putting a lot of resources and efforts is in the patient portal of all of this. Because regardless of what platform is put in place later on, we're hoping that the rehabilitation patient portal can be plugged into any electronic health record that manages everything from goal setting with the patient to planning the intervention to providing self-management recommendations and being able to adapt those recommendations as they progress, and more importantly, be able to plug them into community organizations and resources. We are working with the other thing that I should mention is while Greybox is the main platform creating the transition of care pieces for us, we are working with companies like Wibby, which is Physiotech. Maybe many of you recognize it as Physiotech, to not reinvent the wheel and create educational material, but actually use what's already in Wibby, given that a lot of the clinical programs are already using that. I'm just going to check time. I think I'll take another 5 minutes. Just to say, for the way that we're evaluating the platform is through a stepped wedge trial. So we cannot give in a program some clinicians using the platform and others not, or patients using it and others not. So the randomization needs to happen at the level of the program. And that will allow us using this sort of stepped approach. You see that step in the table, the white area gives us control data. So data when the platform's not in place, and that will compare to the yellow sections, which is data when the platform is in place. So it's sort of an implementation science trial methodology that we're using in order to generate evidence of does the portal work. I talked about the endpoints that we're evaluating, and right now that we're ready to implement, we will do a reevaluation of whether we keep intensity of rehabilitation as the primary outcome, which is in CBAT or EGAP, or whether we should use more function and patient level outcomes as the primary outcome. It would be nice to have your reflections on that as well. We could probably have a whole workshop just on what's the most effective outcome. Where we're going with digital health and rehabilitation, and this project falls within other projects within Brilliant, where we've worked with teams to implement elements of a learning health system approach. So, for example, when we first started Brilliant, we asked teams to identify one best practice that they'd like to implement. It was way back when, before COVID, and they identified implementation of the Mayo Portland Assessment Inventory because it was identified by the ministry as a recommended measure for evaluating more community discharge for individuals with stroke. It had been used in traumatic brain injury. So we went through the process of creating a platform to have the measure, creating dashboards where clinicians can see the scores over time. So they had things like that on the top right-hand corner. And then we iteratively made changes and improvements to the process of implementing the MPI dashboard itself and implementing it within clinical care, with the hopes that eventually it would be used to adjust care plans, patient-centered goals, and evidence-based changes. And then we deployed it across three of the same partners that are involved in this trial to be able to integrate MPI into clinical care. Different sites are integrating MPI into different levels of those three areas of care plans and patient-centered goals and evidence-based changes, but they are all using it at the program level just to compare different subgroups of patients to see who's improving around larger functional and participation areas within the program. There's, always discussion of do we keep the MPI, do we move to other measures? But it gives you an idea that this is the sort of learning cycles that we want to have in order to continuously improve rehabilitation care. But when you have the infrastructure and the digital tools, it also gives you the supports needed to be able to do this efficiently. Same thing with patient-reported outcomes that we want to integrate. I won't spend too much time around it, but we're fortunate to be able to work with CIUSSS Centre-Ouest, who are rolling out proms across the region in different programs to be able to evaluate these learning cycles around using patient-reported outcome data for different purposes at the individual patient level, but also for monitoring services at an organizational level. I'll just end by saying that some of the key takeaways that we've learned, and we're looking forward to seeing what the results of the stepped wedge trial will be in about a year from now, is the learning piece of this. So we've had many discussions with our different partners around as you're doing the co-creating and putting in place digital tools, there are huge opportunities to think about what are we administering as evaluations, what data do we have, and how do we learn from that data, and how can we make it as agile and iterative as possible to support learning. So really thinking about how that learning happens and building that into the process. The core set of digital needs. So can we think of people as people and not by their disease and create digital solutions that address individual needs and patient-centered care as a whole? And then the scaling. How do we scale this at a larger level? And while this is being done within research, we certainly want to work with our partners in order to think about how can the learnings from this either be transferred to other platforms or the platform itself, especially the patient portal plugged into what's coming down the line within Quebec around the digital health ecosystem. So if you are interested in this work, please join we have a citizen partner group. So it's a group of patient partners and community organizations that provide feedback on our research agenda and Brilliant around digital health and learning health systems. We have a lot of work specifically around learning health systems. For example, we've developed a readiness for a learning health system across organization questionnaire that's used as a formative tool to help teams think about, where are changes needed or supports needed to adopt a learning health system approach. And then finally, I need to say a word about the Réseau santé numérique. If you are doing work in digital health, it's really for us to bring together researchers, clinicians, decision makers across the digital health ecosystem in Quebec and plug in with our national and international partners and not to reinvent the wheel, to share our resources and our learning and toolkits in order to support accelerated use of digital health research and advance the science a little bit more efficiently together. And it's building on great work that was done, for example, in REPAR by the technology Axe in REPAR that did a review, for example, of usability tools. And so the RSN's role is to really cartography or map out all those resources, bring them together, and continue to build on them to make them available to researchers and trainees with a strong emphasis on training for students and highly qualified professionals that will be supporting digital health transformation in the future. So I will stop there and see if there are any questions.
Merci beaucoup, professeur Sarah. C'est exceptionnel. Non seulement tu présentes, mais tu offres aussi l'opportunité de collaborer. Merci beaucoup pour ce grand travail. Ouais, si quelqu'un a une question, n'hésitez pas, en français ou en anglais. Je vais commencer par une question dans le chat. My question is, how do you approach competing interests and priorities in terms of design requirement across different user groups, for example, caregiver versus clinical clinicians. Yeah,
Oui. Alors, je vais répondre en anglais, la question en anglais, alors je
en
peut-être.
anglais. Ouais, ouais.
So that's an excellent question, by the way, because there are discrepancies. I showed some of them. Caregivers and patients are a little bit more aligned, although caregivers tend to want more resources and community support. So the way we approach it is we say, what are the resources needed? If it's important to patient and caregiver, what are the resources needed to put in place? And if it's relatively low cost, potential high impact, then we automatically try to prioritize that. We do need to balance it with what the clinicians chose. And if it requires clinician support on the other end, sometimes we won't be able to include it. Like, for example, the area of I want to be able to ask questions and have my answers beyond a certain time in their trajectory. It's hard, the system right now, and this is where we would need policy change to rethink how are we supporting trajectories with technology, would have to rethink how that service is costed and provided. Then if it requires that clinician input and it's not feasible within the current system, then we deprioritize it because the likelihood of it being adopted and rolled out is very low. So it's a constant iterative process, back and forth in terms of using our data to inform the decisions, but then also looking at the feasibility relative to the potential impact.
Merci beaucoup. Diana Zidarov, je m'excuse.
Oui. Allô,
Dites-moi.
Sarah, merci beaucoup pour cette excellente présentation. Moi, j'avais une question sur un petit peu l'évaluation de l'impact de Brilliant. Tu avais mentionné que c'est peut-être le primary outcome à l'échanger, que c'est pas l'intensité des services. Tu as parlé d'amélioration de la coordination des soins, évidemment, l'amélioration des résultats des patients. Euh, de facto, est-ce que tu peux élaborer là-dessus, surtout au niveau comme la coordination des soins versus les soins centrés sur les patients? Comment vous pensez évaluer l'impact? Puis est-ce que ça va être intégré dans la plateforme ou ça va se faire à part?
Alors, je vais commencer avec la dernière question parce que c'est la plus facile. Alors, on essaie de l'intégrer dans la plateforme le plus possible. Et comme tu le sais, Diana, ça prend beaucoup d'efforts d'aller recueillir des données de recherche. Alors, si on peut l'inclure dans la plateforme, c'est qu'est-ce qu'on est en train de regarder avec Greybox, c'est la plus facile. On essaie de prioriser aussi des données qui sont déjà prévues dans le système de santé, dans les trajectoires de réadaptation, principalement en termes de fonction participation, parce qu'on les mesure en général dans nos programmes de réadaptation. Les prom et prem sont moins recueillis régulièrement. Alors ça, on doit réfléchir à ce qu'on peut l'intégrer dans le plateforme Brilliant. Alors ça, c'est notre priorité, d'essayer de faire ça dans la plateforme. Ta question autour de quel outcome, il faut regarder c'était quoi les pain points qu'on adresse et vraiment qu'est-ce que ça va changer. Alors, en termes d'efficience, est-ce que ça diminue le temps de référence à notre programme de réadaptation, le temps de retour à la maison? On peut regarder ces types d'indicateurs d'efficience. La deuxième que je pense, ça va avoir une influence, c'est le patient-centered care. Alors, le patient et la famille qui sont soutenus, plus encadrés parce il y a une communication commune et dans l'équipe coordonnée, mais aussi un soutien quand ils retournent à la maison. Alors, tout notre trajectoire, il y a un aspect retourne à la maison. Alors, est-ce que l'évaluation de soins centrés sur le patient, ça va augmenter avant le plateforme et après le plateforme? Et la deuxième chose, et ça, c'est où je suis pas sûre, est-ce qu'on va avoir assez de temps pour voir un changement de fonction relié à la plateforme autour d'avoir un plan d'intervention qui est progressé, plus personnalisé, in a more personalized way pour chaque client qu'avant. Alors, ça, c'est les trois niveaux que je pense. L'autre chose, ça peut être, mais ça, c'est encore un outcome secondaire, c'est l'expérience des proches aidants. Est-ce qu'ils sont plus soutenus? Mais en termes de outcome primaire, ça doit être les efficiences probablement ou l'expérience des patients en termes de les soins centrés sur le patient.
Ah, merci. Est-ce que je peux poser une deuxième question, Mohamed?
Oui, on a le temps.
Tu sais, on sait qu'il y a beaucoup d'enjeux avec le dossier médical électronique au Québec, mais il semble quand même qu'il y a une volonté de déployer ça. Donc, comment tu vois l'intégration? Parce que est-ce qu'il y a de la résistance de la part des organisations de dire on va attendre le DME ou OK, on embarque? Comment vous allez arranger la fluidité entre deux systèmes un peu parallèles?
Oui. Euh, c'est toujours une question qu'on a, que nos partenaires ont, et c'est influencé un peu quel programme avec lequel on a commencé aussi. Euh, nous sommes dans une stade de transformation de santé numérique. C'est pas une question, est-ce que ça va venir, le IA et le santé numérique, c'est là. La question maintenant, c'est comment est-ce qu'on va le mettre en l'échelle. Et on ne peut pas tout faire. Alors, le dossier santé numérique, on a beaucoup d'espoir que ça va être là, que ça va être au moins dans les prochaines années des exemplaires de succès dans des régions. Et on a toujours gardé ça en tête. Alors, quand on a commencé, il y avait beaucoup de réflexions autour de formulaires dans le plateforme et quel formulaire et comment est-ce qu'on va l'intégrer. C'est quelque chose qu'on doit réfléchir parce qu'on a besoin de cette information pour nourrir le portail patient. Mais on essaie de vraiment, long terme, de regarder ça que où il va avoir le valeur ajoutée, c'est dans deux aspects les décisions cliniques qui doivent être prises à travers les trajectoires et quelles données sont requises pour prendre ces décisions. On peut alors d'avoir ces algorithmes prêts une fois que l'on a le dossier de santé numérique. Et la deuxième, c'est le portail patient. Comment connecter le dossier santé numérique avec une patient portail patient réadaptation quand il retourne à la communauté. On espère avec ce travail que ça va être un peu plus rapide que qu'est-ce qu'on voit avec les timelines dans d'autres pays. Et c'est la façon qu'ils ont le fait aux États-Unis, au UK, c'est d'avoir ces types de apps ou portails qui connectent avec les dossiers santé numérique.
Donc, c'est comme une valeur ajoutée d'avoir le volet portail patient versus ce que le ministère propose actuellement, si je comprends bien.
Oui, exactement. Oui.
Merci beaucoup. Philippe, Troy?
Yeah, I think you just answered my question, but I didn't understand it. How are you connecting or making it possible to connect um, Brilliant to all the different systems? And I think that's what Diana just asked. And so don't repeat yourself. I can get it at another time. So, but thank you for answering that, and thank
Oh,
you,
no
Diana,
problem.
for
Yeah.
asking.
Yeah, no, we're so, and this is where having the Réseau santé numérique, the FRQS, and working with groups like yours, Phil, in terms of knowing what the standards are to get us ready to plug in later on is really important. I will just maybe add one thing. There are existing systems that might not be around in a year or 2 years for rehabilitation. So we're not putting too much effort to connect to those if we know that they're not going to exist later on and trying other ways to get that information for now.
Are you using HL7 Fire? You're setting it up for that?
Yes.
Good. Okay.
Yeah.
Thank you very much.
Merci. Est-ce que quelqu'un a une question? Do you have any other questions? Non? Est-ce que vous avez des questions pour
Euh,
présenter? Oui,
Moi, j'aurais une question.
oui,
Excusez, là, je vais juste mettre ma vidéo.
pas de souci.
J'ai trouvé ça très intéressant et je me demandais si vous prévoyez éventuellement évaluer votre plateforme dans une région éloignée, comme par exemple l'Abitibi. Moi, ma parenté vient de l'Abitibi, puis j'ai un cousin qui a fait un ACV et il y a eu des services à l'hôpital, puis après ça, on l'a chippé à la SAR et le centre de réadaptation le plus près est à 80 km de là. Donc, là-bas, là, il y a vraiment des besoins clients, là, tu sais, comme justement, là, tu sais, comme avoir des ressources au niveau des que soutien par les pairs, de l'information et tout ça, là. Donc, je pense qu'une plateforme comme la vôtre, là, ce serait vraiment, vraiment bienvenue dans les centres éloignés. Mais je me demandais si vous prévoyez aller en région éloignée à court ou à long terme.
Alors, la courte réponse est oui. On voulait même commencer avec les régions éloignées parce que c'est où on
Mhm,
sait qu'il va peut-être avoir le plus valeur ajoutée pour toutes les
mhm.
raisons que vous venez de nommer. Alors, absolument, on a commencé à parler avec des partenaires, mais si ça vous intéresse, je vous encourage de nous joindre dans la communauté Brilliant pour nous aider à réfléchir comment on peut adapter la plateforme, pour aller
OK.
dans d'autres régions. Oui.
Comment je fais pour, c'est ça, moi, je suis patiente partenaire dans certains projets parce que j'ai une maladie neurodégénérative très rare. Mais comment je peux faire pour être patiente partenaire dans un de vos projets?
Alors, j'ai partagé le QR code, mais José, j'ai pris note de votre nom et on va vous contacter. Je pense mon collègue Métayès, est-ce qu'il a vous parlé déjà? Ah, OK, oui,
Ben, je l'avais rencontré dans un congrès, là, puis
oui,
c'est lui qui m'a approché pour, en me faisant part là, de votre conférence d'aujourd'hui.
OK.
Oui.
On vient de voir un échange courriel et votre nom est figuré dans le courriel. Alors,
Ah,
euh,
OK,
je vais vous contacter prochainement, aujourd'hui, demain, pour vous demander une question spécifique, une activité spécifique. Mais ça, c'est la façon. On va. Mais pour jamais, s'il y a personne qui veut nous joindre, il y a le QR code sur la dernière diapo. Je pense, Mohamed, tu vas partager les diapos. Alors, vous pouvez nous joindre en Brilliant ou dans le réseau santé numérique.
OK. Merci beaucoup.
Merci.
Et à vous, est-ce que vous avez des questions? Do you have any other questions? N'hésitez pas, c'est votre dernière chance.
Vous pouvez toujours me contacter après.
Exact.
Chanter
Ouais.
de... Oui.
Non? Je vais voir le chat. OK. Il n'y a pas de questions. Fait que si vous avez des questions, vous pouvez demander directement à Sarah ou aussi m'écrire ou écrire aussi. On peut faire l'intermédiaire pour transmettre vos questions. Sinon, moi, je vous remercie beaucoup pour votre participation à la conférence du CRIR organisée par l'équipe des Axes. Merci, Sarah. Excellent travail. C'est waouh. On regarde ça vraiment avec des yeux qui sont très, très merveilleux, genre. Puis, c'est ça. Vous pouvez quitter. Je vous souhaite une excellente journée.
Merci beaucoup, Mohamed. Merci tout le monde.
Merci, Sarah.
Merci. Bye bye.
Bye.